Before the EKG strips, before the complex monitors and the frantic alarms, there is simply this: a powerful mechanical pump. Every second of every day, the human heart forces blood through miles of vessels, driven by intense, coordinated muscular contractions. The jagged lines dancing across a hospital monitor are not the heartbeat itself. They are a visual proxy, a translation of the electrical impulses that command that mechanical pump to squeeze. Learning to read these rhythms relies heavily on establishing a rigid definition of a normal baseline. Once you know exactly what a perfect electrical cycle looks like, spotting life-threatening deviations becomes a matter of systematic deduction rather than rote memorization. But before evaluating a single wave, we must establish the cardinal rule of cardiac nursing: always assess the patient, not just the monitor. If a screen displays a lethal rhythm, the immediate next step is physical verification. You check the pulse and assess the blood pressure. The disconnected lead wire lying on a bedsheet can look exactly like a fatal cardiac arrest. Without physical context, the EKG is a meaningless stream of data. To decode it safely, we begin by mapping out the exact dimensions of a healthy heartbeat. This diagram shows a perfect normal sinus rhythm, or NSR. The electrical impulse starts in the sinoatrial node, creating the P wave, travels down the pathways to cause the QRS complex, and resets the muscle with the T wave. For a rhythm to be classified as NSR, it must meet strict parameters. The timing is regular. It fires at a rate between 60 and 100 beats per minute, and there is exactly one P wave marching perfectly in front of every QRS complex. We also measure the time it takes for the electricity to travel. Normal conduction demands a constant PR interval between 0.12 and 0.20 seconds, and a tight QRS duration of exactly 0.04 to 0.10 seconds. If the SA node is entirely healthy but reacting to external physiological demands, the firing speed will change. The shape of the waveforms remains identical, but their frequency shifts. This tracing visualizes sinus tachycardia. The electrical pathway is perfectly intact, but the SA node is firing at a rate greater than 100 beats per minute, compressing the complexes tightly together across the grid. Because the primary pacemaker is intact, we focus on treating the speed. Nursing interventions for stable tachycardia include instructing the patient to bear down as if having a bowel movement. This vagal maneuver stimulates the parasympathetic nervous system, chemically slowing the SA node's firing rate. On the opposite end is sinus bradycardia. The individual waveforms are normal and properly sequenced, but the complexes stretch far apart horizontally. The overall rate has dropped below 60 beats per minute. If the patient becomes symptomatic from this slow rate, exhibiting dizziness or confusion, interventions escalate. The nurse administers atropine to increase the heart rate, or prepares a temporary pacemaker to physically drive the electrical system. These simple rate deviations indicate a primary pacemaker reacting to stressors, like fear, pain, or medication. The clinical goal is controlling the speed, not resetting the underlying electrical architecture. Moving away from the primary pacemaker, we look at the upper chambers of the heart, the atria. When this tissue becomes irritated or stretched, it fires its own electrical impulses out of sequence. This diagram illustrates a premature atrial contraction, or PAC. Notice how the regular baseline is interrupted by an early, abnormally shaped P wave, followed closely by a standard QRS complex. While PACs cause a noticeable irregularity in the patient's pulse, they are generally stable. The irritation is localized, often linked to high stress, heavy caffeine consumption, or fatigue. But if that irritation spreads across the entire upper chamber, we see atrial fibrillation. The baseline morphs into an erratic, wavy line. The distinct P waves disappear entirely, and the distance between the QRS complexes becomes completely unpredictable. In AFib, the atria are no longer contracting, they are quivering. This lack of a coordinated squeeze allows blood to pool in the upper chambers, creating a high-risk environment for the formation of life-threatening clots. Treatment follows two distinct pharmacological paths. Physicians prescribe rate control medications like beta blockers or calcium channel blockers to slow the rapid ventricular response, or rhythm control drugs like amiodarone to chemically correct the chaotic firing. If medications fail to restore order, the next step is synchronized cardioversion, a carefully timed electrical shock delivered exactly on the R wave to safely force a return to normal sinus rhythm. There is a critical safety protocol tied to this intervention. If the patient has been in AFib for more than 48 hours, a blood clot may have already formed. The patient must be fully anticoagulated before attempting cardioversion to prevent the shock from dislodging a clot directly into the brain. When electrical irritability occurs below the AV mode, down in the ventricles, the stakes rise immediately. These lower chambers are the heavy lifters of circulation, and erratic electrical activity here is frequently lethal. An early warning sign is the premature ventricular contraction. Here, a wide, bizarrely shaped QRS complex abruptly interrupts the normal rhythm. Notice the complete absence of any preceding P wave. Occasional PVCs occur in healthy individuals, but frequent, repetitive occurrences indicate severe cellular irritability in the ventricular muscle, usually driven by dangerous underlying conditions like systemic hypoxia or severe potassium depletion. If that irritability escalates unchecked, a single PVC multiplies. This strip shows ventricular tachycardia. The rhythm degrades into a rapid, continuous chain of wide QRS complexes, resembling a jagged mountain range firing at 150 to 250 beats per minute. Seeing VTach on a monitor forces an immediate clinical decision tree. The nurse must instantly assess the patient to see if they have a pulse. If the patient is awake and has a palpable pulse, the heart is still managing to push some blood. The care team prepares for chemical intervention with amiodarone or a synchronized cardioversion. But if the patient is pulseless, systemic circulation has completely stopped. The immediate response is initiating high-quality cardiopulmonary resuscitation and preparing the room for defibrillation. Without rapid intervention, VTach often degrades into ventricular fibrillation. The distinct mountain range completely dissolves into an erratic, unreadable wavy line. The ventricles are merely quivering, providing zero blood flow to the body. VFib represents a dying heart, and the sole treatment is an immediate, unsynchronized shock. The rules of defibrillation are rigid. The machine's sync button must be turned completely off. The operator must loudly clear all personnel from the bed, and all oxygen sources must be removed to eliminate fire hazards. If the chaotic electrical activity fails entirely, the rhythm degrades to ventricular asystole. The monitor shows a straight, motionless horizontal line, indicating a total absence of cardiac electrical activity. A common medical misconception is that a shock can fix a flatline. Defibrillation can only halt and reorganize a chaotic rhythm like VFib. It cannot restart a heart in asystole. A flatline requires uninterrupted CPR and advanced life support medications to force a return of spontaneous circulation. This matrix table summarizes EKG diagnostic logic. Isolating the P wave defines atrial function, while measuring QRS width evaluates ventricular health. Narrow QRS complexes point to localized, stable atrial issues. Wide, bizarre complexes indicate highly unstable, life-threatening ventricular emergencies. This split screen illustrates how interventions target specific arrhythmias. Synchronized cardioversion treats organized rhythms, firing exactly on the R wave to avoid the vulnerable T wave in AFib or stable VTach. Unsynchronized defibrillation delivers an immediate shock at any point to halt chaotic, pulseless VTach and VFib. Every clinical decision made from these complex readouts returns to the central axiom of cardiac care. The EKG is merely a diagnostic map of electrical pathways. The ultimate destination of every visual deduction is a precise, life-saving intervention on the human being lying in the bed.